Good evening friends. In this video I am showing various techniques for exposing the frontal recess. Frontal recess is a narrow drainage pathway leading to the frontal sinus. It is difficult to identify during endoscopic sinus surgery due to its small size, complex anatomy and presence of the surrounding structures that can obscure the frontal sinus ostium. The frontal recess is located close to vital structures like anterior cranial fossa and the orbit. Surgeons must be careful to avoid damaging these structures during surgery, which can lead to serious complications. A CT scan of the nose and paranasal sinuses not only gives the extent of the disease, but also gives a roadmap for the surgery. Various techniques for exposing the frontal recess. One is intact bulla technique, axillary flap technique, Wigand's technique after exposing the entire skull base, frontal trephine with fluorescein. Coming to intact bulla technique, as you all know, frontal recess posterior boundary is the bulla. Usually in frontal recess surgeries, the instrument should be above the telescope. You can use 30 degrees, 45 degree or 70 degree angle telescopes, but 70 degree telescope is the best. So if you keep this bulla intact, you are less likely to injure the anterior ethmoidal artery. So your dissection should be anterior to the bulla and posterior to the frontal beak. I am gently separating the uncinate process attachment to the skull base with a J-curate. As the bulla is intact, I am not at all worried about the anterior ethmoidal artery. As you see, this is an easy technique to open the frontal recess. And this is also should be confirmed with frontal glow sign. Dark skinned individuals, this may not be prominent and you should switch off the OT lights so that you can see the glow in the dark. Next is axillary flap technique. After completing the uncinectomy, identify the middle terminate and its axilla. Mucosal incision given and a flap is raised above the axilla of the middle terminate. The bone is nibbled and the recess is exposed. More bone has been removed with a ronger. Edematous mucosa and the frontal cells and its partitions are cleared with J-curate and microdebrider. Packing in between helps us in achieving hemostasis. This is frontal glow sign, where the frontal sinus is trans-illuminated with a 70 degree telescope and examined externally. To prevent lateralization of the middle terminate, I routinely do 3-point Bolgerization of the middle terminate. Weeks postoperative endoscopy showing head-on view of the frontal recess. You can expose the frontal recess even without raising the axillary flap. This is another case where the frontal recess can be viewed by tilting the 0 degree endoscope upwards or using an angle telescope. Next is Wigand's technique. I have the habit of opening the frontal recess in the end. So only after exposing the or delineating the complete skull base. Axilla of the middle terminate is a good landmark for guiding us to the frontal recess. You all know frontal drainage pathway can be medial or lateral to the uncinate process. Again, I use my friend J-curate by just passing it in between the middle terminate to the roof. Identifying the frontal beak, slowly I go posterior, and as I reach the frontal recess, if there is any uncinate process, I'll just lateralize it and I reach the frontal recess. Frontal recess is exactly behind the frontal beak. So once you are palpating the frontal beak, at the moment where you lost the hard bone, it is frontal recess. Now I use a 120 rad to trim off the polypedal mucosa in the frontal recess. You can also use a 60 rad depending upon the surgeon's comfort. You see polypedal mucosa is coming through the sinus. As I am doing this case under general anesthesia, I have the luxury of giving a wash in all the sinuses. Gentle wash is given in the frontal recess. Thanks for watching.